Bismillahirrahmanirrahim. I welcome all of you on today's session for lecture related to diseases of gastroenterology and hepatology. These lectures are primarily focused on, meant for undergraduate medical students, postgraduate residents, as well as general physicians. Let's start with today's session. So we will continue our talk regarding esophageal disorders. We will again start with a case history of a 37-year-old man who has presented with history of intermittent dysphagia for the last 3 years. And it's more for solids and has shown progress over the last 1 year. And now he's admitted in accident emergency with the complaint of food impacted for last 4 hours. Now this can be an emergency right in the middle of the night. And what first thing that you need to do in these patients is an emergency endoscopy because they have food impacted. So irrespective of the diagnosis, that's the first thing which needs to be relieved. So when we proceed to his endoscopy, we see that the food is impacted within the lumen of the esophagus. And once we remove that impacted food, we can see that there is no obvious blockage in the lumen, but the mucosa of the esophagus is showing a ring-like appearance. And there are areas of linear erosions and ulcerations are also visible and white specks are seen in this particular patient. Whenever you see some abnormality, there is no visible blockage to the lumen, you always take the biopsy. So this was the biopsy of this patient. On the left side, we can see it's basically a squamous epithelium of the esophagus. And there is basal cell hyperplasia, there is reticular elongation. But more striking thing is on a higher magnification, we can see these multiples and numerous cells which are eosinophil stained, which are visible in this particular slide. And these basically are eosinophils. So the diagnosis in this patient was eosinophilic esophagitis. We will briefly talk about this, a rare but an important disease of esophagus, which may present with different manifestations. It's a disease which is characterized by symptoms mostly of retestinal burning, dysphagia, or food impaction, or feed intolerance in case of children. One pathognomonic feature of this disease is presence of more than 15 intraepithelial eosinophils per high power field. This is how you make the diagnosis on biopsy. And obviously, you are going to rule out the other disorders who will present with the similar manifestation. And we all know retestinal burning dysphagia is a common presentation of patients with gastroesophageal reflux disease. So we can say it's basically represents a chronic immune antigen-mediated esophageal disease, which is characterized by symptoms due to esophageal dysfunction. And histologically, we have already talked that it is because the presence of more than 15 eosinophils per high power field confirms the diagnosis of eosinophilic esophagitis. Important thing in this disease is the majority of these patients do have some associated manifestations of allergy like atopic dermatitis, allergic rhinitis, and bronchial asthma. Around 40–50% patients will also have peripheral eosinophilia as well. And another thing which favors that this disease does have some allergic background is that the patients do improve on allergen-free diet as well. So let's see. Now, these patients commonly present with retestinal burning. That's an important symptom. And why I'm focusing on this? Because whenever a patient comes to us with retestinal burning, our first reflex response is that it's a case of gastroesophageal reflux disease. That's what we mostly diagnose. And we have already talked about in previous lecture that if there are no alarm symptoms, we can proceed with the treatment. We can proceed with the proton pump inhibitors and all those lifestyle modifications. And that's what happened with these patients as well, because their presentation is similar to a much more commoner disease. So most of these patients are already taking proton pump inhibitors. So it's the poor response to the treatment that should trigger the possibility of alternative diagnosis. One presentation is the food impaction that we have seen in the case that we discussed. There, you will take the biopsy and the diagnosis will be confirmed. But patients who are presenting with retestinal burning and other manifestation, there will be a significant delay in diagnosis because of similarity of symptoms to the gut. So one point to remember is whenever patients of reflux disease are not responding, you are always going to proceed for endoscopy, and you will take biopsy even if there is nothing visible in the esophagus because of the possibility of eosinophilic esophagitis. So what can be the different manifestations? Very typical GERD symptoms can be manifestation of eosinophilic esophagitis. Apart from that, it can present with pain, with vomiting, and obviously because this disease is also commonly seen in children, so feeding dysfunctions are seen in children. But what happens is that because of these symptoms, these patients develop coping mechanism. They know how to handle the difficulty and symptoms of eating. So they start avoiding high textured and bulky foods. They cut the food into small pieces. They lubricate their food well, and they have a habit of extensive chewing and continue taking their meal for many 15, 20, 30 minutes, just because they develop the coping mechanism and they know how to pass that food through the esophagus. But that also contributes to the delay in diagnosis, because they're not going to come for clinical checkup and examination and whatnot. So let's see, how should we diagnose these patients? Peripheral eosinophilia, which is commonly seen in diseases which have got allergic background, it is seen in 40 to 50% of the patient, and it does improve after successful treatment of eosinophilic esophagitis. But the correlation with clinical manifestations and obviously disease is not very strong. Similarly, IgE levels are found to be high in 50 to 60% patients of eosinophilic esophagitis, but it's not predictive of response. And generally, there is no change in its level with the treatment. So we don't use IgE levels and peripheral eosinophilia for making the diagnosis of eosinophilic esophagitis. So primarily, the diagnosis is histopathological, and that is only possible after performing an endoscopy. So how do this disease appear on endoscopy? You may find these linear shearing, linear erosions, and linear ulcerations. There may be linear furrowing, vertical lines, white specks can also be visible. And this is circular. This is very classical of eosinophilic esophagitis. The circular ring-like appearance of the whole of the mucosa is also called Feline esophagus. And then esophageal mucosa is very friable, and it's why it is called crepey paper mucosa, because if you pass a balloon across this esophagus, there are multiple areas of ulcerations and erosions. So it's it becomes very sensitive and very fragile because of this disease. But remember, endoscopic appearance of the esophagus can be perfectly normal in a case of eosinophilic esophagitis. That's what we need to remember. Apart from that, obviously, Feline esophagus, linear furrowing, crepey paper mucosa, white exudates, as can be seen in this picture, like specks or nodules or granularity, that may be visible. And obviously, long-standing patients of esophagitis may end up with strictures, rings, which may be visible proximally or distally. Sometimes there is an overlap of eosinophilic esophagitis with GERD, and you may find islands of Barrett's as well in a patient who has a ring-like mucosa, which is basically due to eosinophilic esophagitis. And we need to differentiate it from this. This is typical of peptic stricture. We can see linear ulcerations and erosions, typical of GERD patients. And we also have to differentiate it from ulcers seen in patients with herpes simplex infection of the esophagus, or CMV infection of the esophagus can also present in form of ulcers. And so you always take biopsy whenever you have an abnormality, ulceration, erosions in the esophagus. You keep this possibility of these 3-4 diseases which can present as ulcerations and erosions, and always take biopsy to make your diagnosis. So biopsy, obviously endoscopic features are not pathognomonic, and we have already talked that patient can have a normal endoscopy as well. And in patients who have got suggestive endoscopic features of eosinophilic esophagitis, only 38% of them do have the evidence of eosinophilic esophagitis. That's why you just don't base your diagnosis on appearance in endoscopy. And then in 10% of cases of eosinophilic esophagitis, the endoscopy may be perfectly normal. So always take a biopsy. And it should be 2 to 4 mucosal biopsy, at least from proximal and distal esophagus, because the chances of picking the disease in proximal and distal esophagus is more. And obviously, if you are thinking of other possibilities, we may take the biopsies from duodenum and stomach as well. And we have already talked about it's the presence of eosinophils and more than 15 eosinophils per high power field, which confirms the diagnosis. So few features are very typical of this, like mucosal eosinophilia, eosinophilic microabscesses, superficial layering of eosinophils, and extracellular eosinophil granules. These are typical. The rest of the features, they can be seen in patients with GERD as well, like basal cell hyperplasia, reticular elongation, and dilated intercellular spaces. These are features which are non-specific. Another thing we need to be careful of is that there are so many other diseases of esophagus which will have eosinophilia. That the most important is the GERD, and apart from that, the celiac, the Crohn infection. So it's not just the presence of eosinophils, it's the number of eosinophils that should be more than 15 in a patient with symptoms which are suggestive of this particular possibility. So how do we treat these patients? Treatment is 3D treatment. 3D means diet, drug, and dilatation. These are the three options we have, and we use it obviously in a sequence. What do we have in diet? Because we believe that this particular disease does have a background allergy to some diet, the constituents of the diet. So people have identified a 6-food elimination diet, then there is a tailored diet, and then there is an elemental diet. We'll talk briefly about these three options of diet for these patients. Then we have options of treating these patients with drugs, which is basically steroids, which can be topical or systemic. And obviously, in cases with complications, we are going to proceed with dilatation as well. What about diet? Now, in diet, we have got three manifestations. One is elemental diet, the other is 6-food elimination diet, and the third is test-directed elimination diet. Now, elemental diet is basically something which has shown the best results. And in over 95% of the patients, there is resolution of symptoms. The difficulty with this is to continue this sort of diet for longer time, for years. That is practically impossible. So another option is 6-food elimination diet. What we do is that we remove 6 common food allergens, that is milk, wheat, eggs, soy, seafood, and nuts. You remove these 6 elements from the food, and there is remission in around 72% of these patients, and around 45 to 50% of patients also maintain this remission. And then the third way of doing is that you check every diet for allergy, for clinical manifestation, like skin prick test and other tests, that to be patch testing. But that has shown low efficacy, both in children as well as in adults. So your major focus is 6-food elimination diet. That seems a bit more practical as compared to the other 2 options in dietary management. So there is a lot of data, and obviously elemental diet has the best results, followed by 6-food elimination and obviously the tailored diet. This is one of the mnemonic which has been created to remember these 6 foods: SFED, WIN, soy, fish, seafood, egg, dairy, wheat, and obviously nuts. So where should we try diet? As it should be the first line of option, and it's especially for children and the motivated individuals, adults who are willing to take this option. This should be attempted before going for the medications. Tolerance to food with foods with this eosinophilic esophagitis is unlikely to develop spontaneously. So inducing tolerance method has not been evaluated. Obviously, whenever you deal with allergic diseases, there are ways of inducing tolerance, but this has not been tried in this particular disease. Foods who have been proven to be associated, like 6-food, they should be restricted indefinitely. And the foods which do not have a definite evidence, they can be reintroduced with careful observation in these patients over the years. What about diet? What about drugs? In drugs, the option is steroids, and these steroids have to be used topically. And you start, and then you have a maintenance therapy as well. Systemic steroids, obviously, you can't use it for long term, and they have got a lot of side effects. They are only used in severe situations, in situations where there are complications like patients with severe dysphagia, with acute weight loss, or inability to tolerate orally. Then you may need systemic steroids. That will be obviously prednisone 1 to 2 milligram per kg. And in that, generally, the symptoms tend to improve in around 7 to 10 days. So there are a lot of studies which have shown benefit with the use of steroids. The common steroids which are used are fluticasone and budesonide, but they have to be used orally. So what is done is basically these drugs are used in inhalers and Zaira, for patients with asthma. So what they do is that those fluticasone puffs are given, and patient is going to swallow that particular diet as given from a meter dose inhaler. The dose should be remembered. For adult, it is 440 to 880 microgram twice a day. For children, it is 88 to 440 microgram twice to 4 times a day. Then budesonide has also been tried as a suspension. It's a liquid which needs to be given. For children, the dose is 1 milligram daily. For adults, it's 2 milligram daily. And we have already talked about the option of systemic steroid, that this is only for the cases where there are complications, where there are severe cases, for getting initial improvement. What is the role of proton pump inhibitors? Proton pump inhibitors do work in certain percentage of patients with eosinophilic esophagitis. So wherever you are suspecting that there is an overlying GERD or proton pump inhibitor responsive eosinophilic esophagitis, there you use it 20 to 40 milligram once or twice a day for 8 to 12 weeks. It does alleviate at least the symptoms due to the comorbid GERD if it is present. People have tried biological therapies as well, because obviously a disease which has got immune and allergic background, this can be an option, but these are not recommended for routine. Drugs like mepolizumab and reslizumab and omalizumab or infliximab, there are studies of benefits from these drugs, but not recommended. So in drugs, you have steroids, and steroids have to be topical, and generally what we use is fluticasone and obviously budesonide in the liquid suspension form, and that has shown very good results. Lastly, the dilatation, third D, that is meant for patients with complication, those who have got severe dysphagia, those who have got strictures. So you will be dilating them either with bougies or obviously with the pneumatic balloon dilatation that may be needed in these cases. What complications we can see in these patients? Mostly strictures, or it may be food impaction, as we saw in our patient. Then in the long run, these patients end up with feeding dysfunctions, malnutritions, and their esophageal caliber remains low, narrowed. So, and sometimes you will encounter longitudinal tears leading to bleeding and ulcerations in the esophagus because of this particular disease. So basically, this is in a nutshell how we are going to deal with these patients. Obviously, these patients present with retrosternal burning and dysphagia and all those symptoms which favors more toward the gastroesophageal reflux disease. So these patients are generally started on proton pump inhibitors. And there is a certain percentage of patients who are going to improve with PPIs. They are basically PPI responsive eosinophilic esophagitis. So once the patient is not improving, you will always proceed for endoscopy. And there the instruction is, if you find everything normal in esophagus in a patient with dysphagia, please do take biopsy. So if it is confirmed to be eosinophilic esophagitis because of presence of more than 15 cells per high power field, then the first line treatment will be topical steroid along with the dietary therapy. We have talked about 6 food elimination diet, and we have talked about the other options. And obviously, if the patient is going to improve, if the patient is improved, you will consider the maintenance therapy. Some form of maintenance will be needed to keep patient free of the symptoms. If patient continues to have persistent dysphagia, you will go for endoscopic dilatation if it is needed. And obviously, in case of failure of topical steroids and failure of other dietary options, the possibility of considering systemic steroids, possibility of considering the biological therapies, which we have already talked about, will be in these patients who are refractory to all those treatment options. Thank you very much.